you. Thank you very much, Morini. Can you see the slides that I have on? I just want to make sure you can see that.
Not
No,
yet.
not yet.
Oh, not yet. Okay. I apologize. I'm going to go ahead and uh, share screen one more time. And okay, this is what I'm afraid of. Okay, one more time. Share screen. How about now?
I think we're getting there. It's loading.
Yeah, apologize. Thank you very much for having me, Dr. Chen and Dr. Siriwardana. It's always been a pleasure working with your wonderful department and um, in progress. Being very excited to do this. Um, and I wanted to see if you can see the slides now. No, not yet.
Sorry, no, not yet.
Okay, okay. Let me do that
If you
one more
want,
time.
Dr. Liao, if you'd like to email them to either me or Dr. Suriwardana, and we can share on your behalf, or Dr. Pitts. Oh, now we see
Okay.
fire. No, we see it. We see it.
Oh, you do? Okay. All right. Let me just okay, let me just go ahead and email that to you because I'm known for not doing a good job with eh, okay. It's always been a pleasure working with your team. I'm going to go ahead and send a slide to you guys just in case. Um, um, I want to talk to you today about really share my experience about how my journey on research, and also very glad to have Dr. Pitts here with me, our new faculty, to also share her experience. Okay, and did we lose our screen? Did we lose my screen again?
No, we can
Dr.
see,
Can you
Liao,
see?
we
the
are
flyer.
we just see the flyer. We don't see any kind of a slides. Maybe you are sharing the wrong screen.
Oh, okay. Okay, let me do that. Let me share the screen. And I send the slides to you, Dr. Siriwana, if you like to, and Dr. Pitts as well. If either one of you like to share, you probably have a much better luck than me. Screen sharing? It says I'm screen sharing. Do I not?
Yeah, we can see the flyer. Is that what you are intending to share with us?
Yes. Can you see the slides?
Yes, yes, yes.
Yeah.
Okay.
Okay,
Can you see the disclosure now?
Yes, we
yes.
can.
Okay, you see the disclosure. Okay, great. So basically, I want to talk to you about three things today. What makes a this side. So I'm going to shift this here. What really makes a successful research for whatever that you're doing? Um, basically, I want to ask you three questions. What problems are you solving? And is the problem research question that you're solving, is it still relevant? And the third question that I really want to get into is obviously you should get involved in everything. Is this something that you should be doing? Basically, is this your battle and your calling? Okay. I'm assuming you can see the slides okay now?
Yes, all good.
Okay, great. So let me cover what problems are you solving. So I'm just going to take, for example, several projects that I'm working on. One of them, I'm just going to take one example is Alzheimer's disease, which is something that I'm passionate about. I do have family members. Many of you may have family members involved in that. So it is really a big problem. This is by far the biggest challenge the neuro community has. over 7 million Americans living with Alzheimer's, and it's estimated that that number will double every 10 years. So if you look at all the top 10 diseases, the NIH fund, whether we're talking about heart disease, cancer, Alzheimer's is the only one that we're really not making a lot of progress, that we don't have a cure. We're really making good progress in all other fields. It really 1 in 3 adults really die from Alzheimer's related diseases. So this is a big problem in so many ways. So what problem are we really solving here? So we actually do have medications for Alzheimer's for many, many years, for the last 30 years, ever since I've been in training. So we have what we call symptomatic treatments, which is just, Aricept or Memantine that treats the symptoms, but it doesn't treat the disease itself. We really don't have anything that could slow the progression or stop the progression. So, you have things like Aricept, Exelon, they treat the symptoms, but we have never really had any disease-modifying therapy that targets the biology of Alzheimer's until recently. So now, in the last 2 years, we have at least 2 FDA-approved medications, Leqembi and Kisunla, lecanemab and donanemab. It's great. It blocks the amyloid cascade pathway, by blocking, one of the enzyme, and it's just blocking different part, and it's the patients that are on, for example, lecanemab, they slow the progression by 22%. It's not a cure. About the same, about 17% of donanemab, and patients are here for the IV infusions every other week for donanemab, so once a month, we have about, many patients that are on this treatment. Finally, after all these years, we do have a treatment for Alzheimer's. So what is the problem? Well, the problem is that 1 in 5 patients, we're talking about 20%, can have what we call ARIA, or amyloid-related imaging abnormalities, or 28% in aducanumab and 17% of lecanemab. These are cerebral edema and cerebral hemorrhage, basically bleeding and swelling the brain. And it is not a small problem, because when patients have that, it is a serious thing. Fortunately, most of the time, patients, it's not severe. They're not symptomatic. We actually don't know about it. They could develop some headache, but we actually do MRI to monitor that. Although I do have 1 patient that did have a stroke and had to be treated for seizure. So I think out of maybe about a dozen of my patients who had ARIA, even though the medication, the people who make the medication say it's safe to go back on it, guess how many of them wants to go back on it? 0. Okay, because once you had a bleeding in the brain and swelling in the brain, you are at risk. There are certain things that we check for. The genetic profile could put them at bigger risk. So how do we get around this? How do we solve a problem? So to do a good research, you need to really think about a problem. What problems are we coming up against, whether it's treatment or anything that you're trying to solve? So the reason that you have ARIA is that because of the blood-brain barrier. The brain is an organ that keeps a lot of things out of it. So the brain forms a barrier called the blood-brain barrier. And in order for the medicine to get into the brain, I have to give it into the IV, into the vein, a lot of it in lecanemab, 15 milligrams per kilogram. So when we give so much of medication, it weakens the blood vessels, and that causes the swelling and the bleeding. So how do we get around? How do we solve this problem? So we solve this problem by a technology, and this is the patient that I told you about. This is an MRI. You can see that she had swelling on the, this is on the right side of her brain, and she actually had some paralysis. She's from Kailua. Now she has epilepsy and taking seizure medication. So although we have a medication, but we have a problem at hand. So what's the solution? So a lot of people think of this as, my question to you is, how do you see a problem when you encounter a problem? A lot of people say, okay, well, there's a problem, then we don't give the medication, then we do something else, or we just let the Alzheimer's progress, but if anything I can encourage you to do today is have a different mindset. When you have a problem, look at it as an opportunity. You can see problem as either a stumbling block or stepping stone. So somebody on the mainland, really smart people on the mainland, see this as an opportunity. Okay, we have to give a lot of medicine for it to overcome the blood-brain barrier. So this is what they did. They come up with a solution called the brain shuttle technology. So they're attaching a module, the brain shuttle module, to the medication. So in this case, trontinemab, which is a cousin of lecanemab. And the brain shuttle shuttles the medicine through the BBB, which is the blood-brain barrier, the medicine into the brain. And because of that, you can see that this is a rat brain without the brain shuttle. This is just a rat brain with the monoclonal antibody. Some of it gets in, but remember the blood-brain barrier keeps a lot of things out. But when you attach the medicine, the brain shuttle to the medicine, look at what happens to the rat brain. Woo! All the medicine rush into it. It just lights up the brain. So not only that, in lecanemab, it takes about 1.5 years for us to lower the amyloid level in the brain. So when we do this, we also measure the amyloid. We want to see how much of the medicine is clearing the amyloid. So it takes about 18 months in lecanemab Clarity trial. So it takes about 18 months. But guess how quickly this new medicine, when we attach the molecule, brain shuttle module to it, how quickly it clears the amyloid down to below 20%? 3 months. Is that great? And so far, no ARIA, no bleeding and swelling that we can see. So, and this is really to do good research. You have to think about what problem are you solving? What values is your project to the overall picture? I have medical students that comes to me and say, I want to do this, I want to do that. But the fact is that if your project, if your idea has no value, it doesn't solve any problem, no matter how great it is, no one is going to publish it. No one is going to fund it. So the first question that I want to challenge you with is whatever project that you're involved in, ask yourself, what problem am I solving? Is this a problem worth solving? So somebody came up with a solution to the brain shuttle. And this is just an example. This graph shows that there are a lot of smart people who are problem solvers in the world. Currently in 2025, I believe this is 2024 data, there's 164 clinical trials, and we're doing about 8 of them here in Hawaii. We're testing about 127 drugs, so we're testing about 5 or 6 of them here in Hawaii, and thankfully 80% of them are disease-modifying therapies. With the 57,000 participants, it takes on the average 13 years to develop a drug. And we're very proud to say that out of those 57,000 patients, at least 200, perhaps up to about 150, 200 patients are from Hawaii. So thank you very much for those who support research in Hawaii. We have disease-modifying biology, which is like the monoclonal antibody that trontinemab that we're testing. Obviously, we have small molecules, like other projects that we're working on, like a DIRA project, and these cognitive enhancers are mostly non-disease modifying. And this doesn't just apply to Alzheimer's project, it really applies to other projects, whether it's Alzheimer's, Parkinson's, and also in Parkinson's disease. Now we have the first monoclonal antibody that binds to alpha-synuclein, that is the pathologic building blocks of Parkinson's disease. So we are also doing a clinical trial. In epilepsy, we're looking at different novel potassium channel blockers. So think outside the box. To solve any problem, do good research, you need to be creative. Think outside the box. How do I solve this problem? How do I overcome the barrier? What is the problem? Think outside the box. And in neuroimmunology, MS, we have a lot of new drugs that are really targeting just the disease process instead of stopping the demyelinating process in MS. Same thing with neuromuscular myasthenia gravis, CIDP, headache pain. We have many research projects, and So on and so forth. The second questions that I would like to encourage you to think about is your project relevant? So you could have a great, maybe you found a great project, you found a great faculty to work with, and that it is a great project. But the question is this relevant tomorrow? A lot of students, they want to work on projects that's relevant yesterday, and maybe relevant today, but think about it. Ask yourself, is this what I'm working on? Is it still relevant 5 years from now? Is it still relevant 10 years from now? So that's the questions that I would like to challenge you today. So let me just give you an example. So in Alzheimer's, we believe that the pathology actually starts, by the time that you have somebody with cognitive impairment, with memory loss, we know that there's amyloid there's extraneuronal and tau intraneuronal. We know that, the pathology is there already. As a matter of fact, by the time we get to cognitive impairment, we think this is at least 15 to 20 years. The process actually starts, if you think of the incidence, prevalence of Alzheimer's, 1 in 8 people at 65 and older, 1 in 3, 85 and older, and 1 in 2, 95 years and older. By the time they get to 65 years old, if they actually have memory loss, this process started when they're in their 40s. So by the time that we actually try to treat them in the 60s, we kind of like just playing catch up. So it's like trying to treat a heart disease after all the arteries are clogged. So how about making a better diet? What do we need to do to find our patients earlier, to treat them, to prevent them from going down that path? So it's not easy. There's several ways. We know that tau pathology, amyloid pathology, amyloid starts a little bit later, and tau pathology. There are several ways to actually detect those, traditionally. So in 2011 and 2018, and also this year is some kind of a milestone in those people who are in our field. When I was doing my neurology residency, we define Alzheimer's as pathologic findings. Patients get a brain, basically autopsy of the brain. That's how you diagnose Alzheimer's. But what good is it? The patient is dead. What good is that? So in 2011, they kind of say that, what, we don't. It should be defined by some biomarkers. It could be an amyloid or tau. And with some clinical findings, you have to have some memory loss. And then we realized that, my gosh, by the time they have memory loss, it's already too late. So by 2018, they said, you know what? We don't care whether you have memory loss or not. We just want to know what's going on in your brain. Do you have that hallmarks of Alzheimer's? Do you have amyloid and do you have tau pathology? And in 2025 this year, AAIC, Alzheimer's Association International Conference in Toronto, that was an ad. They said, actually, we're going to replace, and we know this by PET scan and spinal tap and amyloid PET scan, that we actually blood biomarkers is going to be the next big thing, because who wants to get a spinal tap? It's invasive. So the 3 ways to really diagnose them is through the spinal tap, CSF, looking for amyloid, PET scan, amyloid, and blood biomarker. I don't want to go into the details. It is a little bit granular, and So what is the problem with spinal tap and PET scan? I mean, for the obvious reason, spinal tap is invasive. Nobody wants a spinal tap. They don't need to take it. Amyloid, at least, is not invasive, but is taking a radioactive substance, getting injected in your body, and looking for the amyloid substance. And right now, we don't have any amyloid PET scan on the island, so we're still flying our patients to California. Hopefully, we have that soon. However, if you're working on spinal tap and amyloid, there is a word of caution. because there are some, the amyloid and the tau levels in spinal fluid and PET scan are what we call surrogate markers. They are not real reflection of memory or cognitive function. Plus, 20 to 40% of elderly have amyloid positive PET, but no memory loss. Do they have Alzheimer's or do they not have Alzheimer's? Plus, a certain number of patients with amyloid and tau pathology, they have negative PET scan. They have positive CSF but negative PET scan. Or what is really the disconnect here? Well, the disconnect is because these are surrogate markers. These are actually not real measurement of cognitive function. So memory are synaptic function. You can't really measure memory because the only way to measure memory, I tell my patients, ask them what they remember, but if they don't remember, how do they tell you? Memories are your thoughts. I can't exactly read your mind, So these are what we call structural or surrogate biomarkers. What is the disconnect? The disconnect is synaptic function in the brain occurs years, the dysfunction occurs years before the protein deposits, whether it's amyloid or tau, and it can remain silent for many years because I have patients, for example, I have a UH professor who has his spinal fluid it's just dumped with amyloid. He has he's atrophied, his hippocampus is atrophied, he's got almost no memory storage, but he's still highly functioning. Why? Because he's highly educated, he has a high cognitive capacity. It takes years of depletion. The way that I explained to the patients, you have a water reservoir, it takes years of depletion before you even realize that I'm running out of water. So this UH professor is still functioning, probably had Alzheimer's for 30 years, but barely manifesting the symptoms now, because the disconnect is that memory, CSF and amyloid PET scans are not surrogate markers. So are there other better markers? And this is what I discovered this actually very by luck or serendipitously. I was working on a research project with a company called Dept, and they were testing a drug to restore synaptic function in patients with mild cognitive impairment or mild Alzheimer's. And they were not interested in measuring CSF, amyloid, or tau. I was curious. It's like, why are you not interested? This is what everybody's doing. So this is about 7 years ago, they already kind of realized that, what? The amyloid, PET amyloid, and CSF amyloid are not a good reflection. What we really are measuring is we're measuring synaptic function. So instead, they're measuring a test called ERP, evoked related potential, P positive 300 latency. What is that they're measuring? Basically, they're measuring EEG brain signals. And so I have spent years looking at EEG brain signals in Alzheimer's patients since I was a resident. We're talking about 25 years, and I was curious. I said, how do you do that? It's impossible because EEG brain signals are small and it varies among patients, and you have to measure it through the scalp and the hair. There's so much artifact. There's lots of noise and artifact. It's almost impossible to interpret what is brain signals and how do you measure it. And it varies from people to people, and it takes years of training for a neurologist to read EEG. And I actually had a medical student work on a project with me looking at EEG of Alzheimer's. And she started the project when she was first year medical student. By the time that she got IRB approved, she was fourth year medical student. And now she's actually a fourth year OB resident here in Hawaii. I won't tell you who it is. So these things really took time. It took me 7 years to even put out a paper on Alzheimer's EEG findings. And I was curious, how are these people doing this? And obviously everything goes back to AI. Artificial intelligence, that really changed everything. So instead of having a neurologist sit down and sorting out thousands and thousands of hours, hundreds of hours of signals, they just train AI to sort the signals, the brain signals out. So This company have started using a biomarker, electrophysiology advanced monitoring. So basically, they're doing cognitive testing while they're looking at brain activity. The way that I explain it to my patient is, think of it as a lie detector. A lie detector doesn't care what you say or don't say. It looks at a function of your body. So in this case, it looks at a brain activity. So we ask the patient, remember this, remember that, and they hit the button, but we're actually looking at the synaptic function, so this is an EEG platform. And basically, this is a brain-computer interface that establishes a direct communication between the brain and external device. So we transferred all those signals, synaptic signals, into the computer and work with the AI company in California, Advanced Brain Monitoring, and they analyze those. They have a database of thousands of patients already, and they did it. And I was so upset at them because it took me 7 years to publish a paper. And these people did it I asked them, how long did it take you guys to figure it out? They kind of say, well, 7 months. I got a feeling they did it in 7 weeks. What I had to took me 7 years to do. So I was so upset at them. I said, if I can't beat them, I'm going to join them. So about 4 years ago, we started working with them and looking at using AI algorithm, machine learning to look at brain signals to sort this electrical signals out. And I really believe that this is the future, and it has generated some excellent data so far, where it allowing us to sort out Alzheimer's patient from normal aging. And when they have Alzheimer's signals, it allows us to sort out how severe they are. So number one is diagnosis, accurately diagnose our patients. We don't need to do spinal tap. We don't need to put them to amyloid PET scan. Don't need to fly them to California. The second thing is to sort things from other dementia, including Parkinson's dementia, Huntington's chorea, diffuse Lewy body. That's other frontotemporal dementia, vascular dementia. It has the capability to sort those dementia out. Isn't it amazing? AI is really changing the landscape of how we really diagnose them. And I think this is actually going to get even better over the next couple of years. And without getting into nitty-gritty, this is just the differential signals on diffuse Lewy body dementia, Parkinson's dementia, Huntington's healthy control, and Alzheimer's dementia. You can see even colors are different. So this is the report that I get from my Beam AI memory test. Basically, it's these are subjective signals, synaptic function. Health basically tells me the health of the synaptic function, and so I'm no longer depending on a surrogate marker like a spinal tap. And we actually presented some findings at this is AIC Tokyo, Japan. We actually work with the company and work with the company and generate some data. Working with Shay, Kira, Jeanette, Kylie, and Michael. There are 5 medical students that work on the project with us. We presented the findings in Tokyo. Here's our Alzheimer's, and we created an Alzheimer's neural network EEG lab here with some of the medical students that we're working with. Michael, Jeanette is 4th year, Kira 3rd year, and Kylie's second year, and our EEG tech in the back. And so we are continuing this project, and Dr. Pitts will be working with the AI company also to look at biomarkers, beam data in CSF positive. We actually have those data, CSF positive patients, ApoE4 positive patients. And now with the blood biomarker p-tau217, we have those data that we're going to really drill it down. And I think these are really very helpful data that is relevant. That's what I'm trying to tell you. Work on a project that's going to be relevant 5 years from now, 10 years from now. I'm not saying that don't work on spinal fluid or don't work on PET scan, but please don't work on a project that's relevant today and yesterday and going to be irrelevant 2 years from now. So think about the project that you're working on. Is it going to be relevant 5 years from now? Okay, so the third question is that that you should be asking yourself if you want to be successful in doing research is this a project that for me, is this my battle to take? Is this my calling? Um, we all have finite number of time and days in our life, and I think what separates a successful researcher from a researcher that's mediocre is the successful researcher knows what they're doing and they go after it and they're focused and they say no to everything else. That's a distraction. A mediocre researcher try to do everything and do them at mediocre. So let me just give you an example. So I was approached by a company that is developing a novel therapy called CAR-T cell therapy. It's been used in cancer. So basically what they're doing is they're taking blood from the patients, basically looking at T cells, which are, it's immune cells, and separate them from your serum. And then the T cells are genetically altered to have special receptors called CAR is a chimeric antigen receptors. So they insert this into the T cells, these receptors on the membrane of T cells. So these T cells now, the patient's own T cells now become CAR T cells. And then these are grown in a petri dish in a lab. And then they get injected back in the patient. And how is this helping the patient? These T cells will then fight the cancer cells. Isn't it amazing? Using your own immune system to fight cancer cells. You're not using a foreign substance. You're just boosting your own immune system. So there are certain neurologic diseases like myasthenia gravis, even multiple sclerosis that stems from a dysfunctional immune system. So this company wants to take T cells from our patients with myasthenia gravis and harvest them and then genetically alter them, insert the CAR in the T cells, and then inject them back. So this project actually requires some significant expertise from oncologists because it could be dangerous in the initial stages of harvesting the cell. There could be reaction, there could be infection, or they could die from having bleeding. So I had an oncologist on board. I had a nurse. I had the neurologist specialized in myasthenia gravis at the meeting at a table. But eventually, eventually after about a month trying to work at this project, and anybody who knows me knows that I don't give up easily. I persist. I work on a project. It gets to a point that I don't think it's going to work. And it's going to take. It's not. I'm pretty sure if I keep working at it, I'm going to break through. At some point, we're going to have breakthrough, but it's going to take my energy away from other projects that are more important. So just remember that you are finite. You have certain number. We are all given certain number of hours and days in our life. Think about what's important. So eventually, I had to basically give up. This project, and I had to say no to this project. But when Dr. Siri Wardana wants to do a project, it's a yes because his projects are always great and it's worthwhile. But other projects maybe not. So you got to say no. So a good researcher will pick your battles wisely. You can't say yes to everything. Sometimes it could be technical factors. Sometimes it could also be personal factors as well. Sometimes you got to say no because of personal things. Just to give you an example, about 6 years ago, I was approached by a medical school to chair a department of neurology. I won't tell you which school it is, but it was an amazing opportunity. It was such an honor, to chair a department and to create a new department. And it took me 6 months. I told the dean, give me 6 months to think about it. And after thinking about it for 6 months, I realized that this is just not not what I really want to do. I mean, I could do it, but at the end of the day, you know, I'm going to be, it's going to, it becomes a distraction. It's going to take away the calling in my life. What is important in your life? What are you called to do? So I had to say no to that amazing opportunity. So sometimes it could be personal. Sometimes you got to say no to things so that you could have time for things that are important in your life. Okay? Not every battle in your life is worth fighting for. Some battles you just got to kind of let it go. It's not you. It's not your battle. The CAR T cell therapy, it's not to be done in Hawaii. Let UCSF, let UCLA do it. You don't have time to get involved in things that aren't between you and your destiny. I really believe that every single one of you that are here on this lecture, you have a destiny. You have a calling in life to do something great in your life. You have the seed of greatness in you. Think about think about some things you need to pursue. You can't give up, but some things are just distractions in your life. There are really three types of people in the world. People who make things happen, people who watch things happen, and people who wonder, what the heck happened? What kind of person are you? If you want to be a successful researcher, be the first person. Make things happen. I hear this a lot. I had neurologists, the older ones that have retired in Hawaii, they would come up to me, hey, I heard that you're doing this and that. This is so great. You know what? I've always wanted to do this. I always wanted to do research. But I just never did it. I just never had time to do it. Don't tell me that. You had the same opportunity that I had. Make things happen. Procrastination is your biggest enemy. You are your biggest enemy. You are the biggest barrier between you and success in your research career and your destiny. I certainly, part of being a successful researcher is having a good team. So I have to give credit to my wonderful team, including Dr. Pitts, who is going to tell you about her journey as a PhD. So this is some of my wonderful faculty in the neuroscience and some of the wonderful students, the medical students and the brain students that are here that have enable us to do what we do and make a difference for our community every day. This is the brain students. The brain stands for Brain Research Innovation Neuroscience. So to summarize, making of a successful research, you have to answer three questions. What problem are you solving? The bigger the problem, the bigger the reward, basically. If you're just looking for the small problem, expect a small reward. But if you're tackling some of the most challenging problem, expect a great reward. Problem solving is a choice. I always tell my staff, don't come to me with a problem, come to me with a problem and a solution. That's the kind of people that I'm looking for. If you want to succeed in your life, be a problem solver. Don't go to Dr. Chen with just a problem. Go to Dr. Chen with a problem and a solution. I think you are going to stand out as a problem solver. When Dr. Chen has a project that he's looking for students, you're going to be the first student that he's going to look for. Second question is solve tomorrow's problem and not yesterday's problem. Think about a project that you're working on. Is this going to be relevant 2 years from now? Is this going to be relevant 5 years, 10 years from now? Choose your project wisely. Use your time wisely. And that's really what third thing is. Choose your battle wisely. You're not supposed to do every project that comes across your table. Every ideas are not for you. Some are just not your battle to do. Choose them wisely. Lastly, a lot of students ask me, is this research project is going to be publishable? Is it going to be successful? I always tell them it really depends on you, because what do you put into the project? A lot of students just doesn't want to do anything. That you can't get a hold of them. They don't reply email. They don't return phone calls. It took them 2 weeks to reply an email. They don't return phone calls and they don't get anything published. And then they get upset. I'm like, you reap what you sow. You can't reap what you don't sow. This is the simple facts of life. So if you really want to have a plentiful harvest, you're going to be a successful researcher. Make sure that you sow generously. Be the first one show up. Be the first one to show up at work, at your lab. Be the first one to show up at Dr. Siriwardana's class. Sit there and be the last one to leave. And after everybody else leave, ask Dr. Siriwardana if there's anything that you can do for him. Clean up the classroom for him if you have to. Turn off the lights. Be the last one to leave. First one there, you reap what you sow in life. If you're not successful in life because you have not sown. If you have been successful in life because you have sown generously. It's as simple as that. Nobody can, simple as that. I want to finish. I don't want to take up too much time, so I give some time to Dr. Pitts. I want to finish my session with you by telling you about a story of an intern that was here with me in 2015. His name was Michael Sonson, and you can see that on the left-hand side. This is actually in 2016. He was just a research student that showed up. As a matter of fact, I almost never had him. How did he come to do research with me? It was because there was a lady at church. Her name is Jill, and she came up to me one day. She knew that I was doing research, and she said, Dr. Liow, I know that you do research. Can you do me a favor? Can you please call this student? His name is Michael Sonson. I told Jill that, Jill, I'm not going to call any random student to do research with me. I have many students that are doing research with me. I'm sorry, Jill, I'm not going to just call up any random student. But this lady never gave up. Every week at church, she looked for me and she hunted me down and asked me, did you call Michael? Did you call Michael? To the extent that I was running away from church. When I see her on that side of church, I ran away from Jill because I didn't want to answer her. So I've never done this ever before. Out of the blue, I just called this kid just to get Jill off my back. I said, Michael, just show up at the clinic. So I put a white coat on Michael, and I just said, just rotate with one of our neurologists. So I have found throughout the years that if you just ignore students, just make them do a shadowing and rotation, they probably go away in about 2 or 3 weeks. Just ignore them. And Michael came on the clinic and said, do you have any research? I said, I don't have any research project for you. And then after 2 or 3 weeks, I realized that Michael is not going away. He invited himself to all the lectures, invites himself to all the programs that we have. So one day I sat him down. I said, Michael, what are you doing with your life? He said, I'm taking a gap year between my college and I'm applying to medical school. I said, what medical school are you applying to? He said, Johns Hopkins and Harvard Medical School. I said, what did you get in your MCAT? He told me what he got for his MCAT. Apparently, it was 99.9 percentile. MCAT. I said, sit down right now. I got a research project for you right now. So I put him to do research with one of my fourth-year medical student, really bright student. He's a neurologist right now in Phoenix. His name is Liang Wang. Great student, really bright student, putting together a database of my Alzheimer's database. But Michael Sonson was so brilliant, this kid. He changed all the data, he changed everything, and he actually outdo one of my best fourth-year medical student. I was so impressed with this kid. I said, Michael Sonson, you cannot come here anymore unless I'm going to hire you. So I knew that he takes the bus from Waipahu, that's where he lives, to come to St. Francis. So you can't come here anymore unless I hire you. So I hired him to work at my front desk. He was checking patients in. I had a position open. He was just checking patients in. And he was such a great employee. And I promoted him to be a research, so he was just right here. He was just checking front desk in. And then soon I promoted him to in my clinical research team. So he was a research assistant. This is in 2017. And great attitude, great student. One day he came to the conference room and his expression just changed. He's not the same person. I asked him, Michael, what happened? Something is wrong. He said, I wonder if I should share this. Well, okay, I'm going to share this anyway. I'm too old to worry about what people think. He said Jepson rejected him as a rejected his medical school application. You know, and he was really upset about it. You know, he was devastated. His expression was just totally devastated. Then he asked me permission. He said, Dr. Liow, if you don't mind, I'm just going to go home. I'm going to think about things and I'm going to ask God for an explanation. And I said, go ahead, go home, Michael. So I know he takes a bus home and I was really worried about him. So I drove my car out to the bus stop and I found Michael Sanson sitting at the bus stop with his head down this way and totally rejected and depressed. And I said, Michael Sanson, get in the car. And I said, life doesn't work that way. So we have a little talk, and I took him home. Next day he came back and he said, Dr. Liow, can I work for you for another year? I said, Michael Sanson, you can work here until Jesus comes back. And so anyway, he worked for me for another year. Long story short, the next year he got into medical school, but not only that, he got into NYU and combined NYU neurology program. Because he combined his medical school and neurology 4 years, they will shorten his medical school to 3 years. So he did not lose a year. Not only that, that was the very first year NYU offered a full ride scholarship to go to medical school. So he actually got a full ride scholarship to go to medical school at one NYU. So I don't know where you are in your career, where maybe you could have applied for medical school or you think you're applying for medical school, but I wanted to share this story with you. And not only that, this is Michael Sanson, and starting next year, 2025, he's right now an Alzheimer's neurologist at UCLA Cedars-Sinai. He's going to come back and work for me. He's going to come back again and work as a neurologist for me. So why am I sharing this story with you? I'm sharing this story with you because perhaps some of you could identify with him, his journey, how you have a little snack in your life. Don't get discouraged because everything happens for a reason. As a matter of fact, one of my employees is actually a previous student at Dr. Siriwardana's class. Can you tell who it is? I won't tell you who it is. They're all dressed up for Halloween here. I'm going to finish and let Dr. Pitts go. Success in research or success in life is not how high you have, how much you have accomplished, or how much money you can make, how high you climb, but it's the difference that you made in someone else's life. The difference that you made. And so look at success with a different perspective if you can today. And with that, I will turn it over to Dr. Pitts to let her share her journey as well. Dr. Pitts, will you please?
Thank you, Dr. Liow. Dr. Siriwardana, does this lecture end at 1?
Yes, at 1.
Okay. If you'd like, I could leave my email and we can defer to see if there's any questions. Would you prefer that I do that?
Yes, that would be fine.
Okay, sure. I'll put my email. I'm happy to talk to students about the path to getting a PhD and kind of what the differences are between the MD and the PhD track. So I'll leave my email in the chat. You can feel free to send me questions and things. And otherwise, we can open it up to questions for Dr. Liow.
Actually, we have 7 minutes, so you can share some additional details if you have prepared.
Okay, sure.
Please do, Dr. Pitts.
Okay, I don't have any slides. I was just going to talk a little bit. I started out with a bachelor's degree in psychology. I knew that psychology and the brain was a big interest for me. After college, I started working with kids with autism. I was very interested in helping them. But I was very quickly frustrated that for one thing, I didn't know a ton about autism, right? As a kind of tech working with kids with autism, delivering their therapy, I wasn't taught a lot about the causes and what's going on in the brain and how we can help to improve this, other than giving them some tools to help cope with the things in their daily lives that they had trouble with. So that frustration led me to want more out of school. So I was considering both an MD and a PhD. I had done all of the, pre-med and pre-PhD requirements to do either one. And in the end, I decided on a PhD because I didn't feel like we knew enough about autism to really make a difference in that world. We didn't know enough about what was causing it and how to treat it to get real results from it. So that's why I chose a research route. I wanted to really dig into try to solve some of the problems so that we could come up with some better treatments for it. So I ended up doing a Master's of Science first in neuropsychology. That gave me a lot of background to understand some of the both cognitive deficits associated with autism and other developmental disorders. It also helped me to understand what's going on in the brain with developmental disorders and to be able to provide some context to my what I already understood of treating those disorders. I then went on to do a PhD. I wanted to dig more into that research, dig into the kind of underlying how we do good research and how we can make sure that we're kind of digging in deep enough to solve some of the problems and come to the endpoints where we're helping patients to the best of our abilities. I have some pros and cons to the PhD track. I don't know that I have time for that. So maybe I'll just kind of end with my summary points. So kind of some things to keep in mind when you're looking for like either a PhD or an MD program. For one thing, think about funding. I didn't know this when I started my PhD, but a lot of PhDs are actually fully funded. So if you find a professor who has grant research, it's a very good mutual relationship where you can help them and support their research, and they can help you by providing funding for your studies and supporting your research also. You should also think about hireability. So, for example, with an MD, it's relatively easy to get a job as a doctor, right? Everybody's looking for doctors. They're in high demand. It's harder to get a job as a PhD. So most PhD jobs are in academia. It often requires that you move to kind of where there are job openings. And so you want to consider, especially when you're looking at topic or specialty, that you think about how easy it's going to be for you to be hireable and how that fits into kind of the plan that you have for your life. And speaking of a plan for your life, you should also think about your long-term lifestyle and flexibility that career track will offer you. The PhD route is actually very flexible in the sense that you can kind of say yes or no to projects depending on how much time and energy you want to put into it. And then also definitely pay a lot of attention to the quality of training that program is offering you. I can't stress enough how important statistics are in your studies. So if you go the MD route, especially, make sure that you are seeking out higher level statistical training if you want to do research in the future. I see a lot of medical research that just doesn't use strong enough statistics to make a compelling argument in what they're trying to say. So definitely don't skimp on the stats. Make sure that you're getting good experience from whatever program you choose. Whether it's research experience, make sure that you have access to data that you can dig into to kind of help some of those stats really, to get some deeper understanding of what those stats mean to a data set in a data set. And then lastly, make sure that you find a professor that you can work with that you share interests with. That's so important when you're learning to do research. It's easy to kind of fall into the trap of, well, I have this opportunity, so this isn't really what I'm interested in, but I'll go this route to get some experience. And that's fine if that's all you have available, but it's important that you also kind of scratch the itch of what your interests are and find a mentor who can support those interests so that you can go further on your own path. Okay, I'll stop there. Thank you for your time. Thank you for having me.
I totally agree with what she said, and especially the part about MD not having a strong stat. I think she's talking about me, and I have to say that it's been such a privilege and honor to collaborate with Dr. Chan and Dr. Sri Wardana's department because most research projects, the statistics and quantitative health is really sometimes what makes or break the project. I really do encourage you to really make the best use of your time there. And if you're weak in stats, make sure that you have great collaborators. For myself, we have Dr. Pitts, Dr. Sri Wana, and Dr. Chan. Thank you, Dr. Pitts, and we're just beyond excited, thrilled to have Dr. Pitts back in our department. Thank you so much. Thank you for your email as well, Dr. Pitts.
Well, thank you both for your presentations and also for weaving in some sage advice for our students that is invaluable for them. Thank you for your time as well. If there are no other questions, I know we're a minute past the hour for this seminar, so I apologize. I don't think there'll be too much time for questions at this time, but Dr. Pitts has provided her email if you have any subsequent questions for our presenters today.
If I could just also thank some of your staff at the quantitative health, especially Masako, also Carl. Thank you for working with our Japson medical students. Your input have been valuable. And I have told every single one of my medical students to include you guys in as co-authors on the abstracts and the paper. And if they don't do that, please do email me. Because we want to give credit to where credit is due. And I do usually try to check but I just want to thank the not just the faculty but the staff. Thank you, Muniri, for coordinating this, and it's always our pleasure and honor to work with your department.
Great. Thank you so much, Dr. Liow. We really appreciate your support over the years. All right. Aloha, everyone. Thank you.
Thank you so much, Dr. Liow, for the excellent presentation. So, Dr. Pitts, great to have you both, and hope to see you again at some point.
See you soon. Thanks, sir.
Thank you.